Osteoarthritis has long been considered to be the progressive wear and tear of cartilage associated with aging and excess of mechanical stress. My mission today will be to try to convince you that osteoarthritis is more than a wear and tear disease, and also involve all the joint tissue, but also inflammatory responding, including the innate immunity. Osteoarthritis is a disease that currently affects 350 million of people worldwide, mainly women, and its economical impact represents between 1 to 2% of the gross domestic product of industrialized countries. These figures will sharply increase in the coming decades due to the demographic trends, the increase in the life expectancy, and the number of overweight and obese subjects. What is very important also to note is that osteoarthritis is a cause of sedentarity in young adults. For many years, osteoarthritis has been considered as a wear and tear of the cartilage characterized by the progressive loss of cartilage, which can go as far as bone denudation, as you can observe here on these figures. Until 10 years ago, the chondrocyte was considered to be the main conductor of this degradation. It was demonstrated that in osteoarthritis, chondrocyte underwent a metabolic dysregulation induced by mechanical stress and or by pro-inflammatory factors. This metabolic dysregulation was mainly characterized by overproduction of catabolic factors, including metalloproteinases, reactive oxygen species, and by a decrease of the anabolic process, mainly a decrease of the synthesis of extracellular matrix components, including type 2 collagen and aggregate. This metabolic imbalance led to the loss and the release in the joint cavity of fragments of bone and cartilage, but also of product coming from the degradation of matrix components. And all these factors, these mediators, are now called the DAMs, the damage associated molecular pattern. But osteoarthritis is considered now as a serious disease by the FDA, for which there is no cure. And I would like to share with you this definition proposed by the Osteoarthritis Research Society International. And I would like just read this definition and share that with you. Osteoarthritis is a disorder involving movable joint characterized by cell stress and extracellular matrix degradation initiated by a micro and macro injury that activates maladaptive repair responses, including pro-inflammatory pathways of innate immunity. The disease manifests first as a molecular derangement, and this comes from the abnormal joint tissue metabolism, followed by anatomic and or physiologic derangement, including cartilage degradation, bone remodeling, meniscus degradation, joint inflammation, and this can culminate in illness. Now, using this picture, this graph, I would like to summarize the recent advance in the knowledge of OA physiopathology. OA physiopathology starts first by a cartilage lesion induced by mechanical stress, for example, and the release of the extracellular matrix. This release of the extracellular matrix induces the activation of the chondrocyte, which may change of phenotype, and mainly undergoes a changing in catabolic phenotype. This catabolic phenotype is characterized by the release by the chondrocyte of pro-inflammatory cytokines, including IL-1 and TNF-alpha, which can activate two main signaling pathways involved in cartilage degradation, NF-kappa B and Wnt signaling pathway. By this activation, chondrocytes start secreting a lot and many metalloproteinases, including the aggregatinase, but also collagenase like MMP1 and 13, and also MMP3, which is stromelisine, which can degrade directly aggrecan. In parallel, they synthesize less aggrecan and type 2 collagen, leading to cartilage degradation and disappearance. Recently, it was demonstrated that cells and chondrocytes located in the deep area of the cartilage may synthesize a rankle, which is a factor that can stimulate osteoclast and activate bone remodeling. Bone remodeling leading to sclerosis of the subchondral bone. Recently, in my lab, we have demonstrated that osteoblasts coming from the sclerotic area of subchondral bone and comparing to the neighboring one have a fully different phenotype. And they overproduce Rankin and I6, and by this way contribute to bone remodeling. But also, these factors may reach the overlying chondrocytes through microcracks and through channels, and by this way activate the overlying chondrocytes and creating a loops between subchondral bone and cartilage. But they also produce some factors like VEGF, which may stimulate blood vessel outgrowth from the bone and the invasion of cartilage by blood vessels, and the arrivals of blood induce the differentiation of chondrocytes to hypertrophic chondrocytes and the mineralization of the matrix. It was also demonstrated that some fragments, complement factors, PGA2 cytokines released from the cartilage in the synovial fluid may activate through receptors which are named PRR for pattern recognition receptors, may activate cells present in the synovial membrane, and these cells in turn secrete more and more MMP cytokines, but also other factors which may directly degrade the matrix, or through PRR may stimulate the chondrocytes to overproduce catabolic factors. By this way, you have another loops between the cartilage and the synovial membrane, which contribute to explain the use of NSAIDs in the treatment of osteoarthritis. But quite recently, understanding of osteoarthritis has become even more difficult with the identification of several phenotypes. At this time, we identify 6 different phenotypes: the mechanical injury-driven phenotype, the aging-driven, the cartilage-driven, the metabolic syndromes-driven metabolite, the subchondral bone, and finally, the synovial-driven phenotype. These phenotypes can be defined and explained by a specific molecular pathway named the endotype that explain the observable properties of the phenotype. Until now, 9 endotypes have been identified and associated to molecular endotypes, which are characterized by circulating biomarkers that we can measure directly in the blood or in the urines. Today, our attention will be focused on the synovitis-driven phenotype, which is associated to 3 endotypes: the high level of local inflammation, the high levels of systemic inflammation, and finally, the phenotype characterized by role play by macrophages and neutrophils. And these endotypes are, of course, defined by molecular endotype, including biomarkers like, for example, COL2 nitrated, or cytokines like TNF-alpha, IL-6, or also MMP, for example. I suggest now that we focus on local inflammatory reaction, taking place in the membrane synovial or in the knee in the fat pad, which is also called OFA ligament. It is commonly believed that synovitis is secondary to the degradation of cartilage associated with chondrolysis and the severity of symptoms. You can observe here that from anatomopathological point of view, synovitis is characterized by villus hyperplasia, which is characterized by an increase of lying cells layer and hyperplasia, but also by perivascular mononuclear cells infiltrate, and also in the deep zone of the synovial membrane by fibrosis. In the advanced OA stage, we can also observe lymphoid nodes and the accumulation of adipose tissue in the deep layer of the synovial membrane. Synovitis is also associated with adaptive immunity and innate immunity. Innate immunity is mainly driven by macrophages that may polarize according their environment, according the inflammatory status of the joint in M1 or M2 macrophages. Innate immunity is triggered by stimulating agents. In these stimulating agents, we can find damage-associated molecular patterns, the DAMs, including the alarmins, pathogen-associated molecular patterns, the senescence-associated molecular patterns, which are a lot of factors released by senescent cells in the joint, but also by complement factors. These stimulating agents act through receptors, and these receptors are named pattern recognition receptors, including toll-like receptors, not-like receptors, but also receptors for advanced glycation and product. And the response to the stimulation are the overproduction of matrix metalloproteinases or aggregatinase, also reactive oxygen and nitrogen species, which are all involved in the degradation of cartilage matrix, and downregulations of cartilage extracellular matrix components and chondrocyte apoptosis. It is clear that in osteoarthritis, synovitis, and cartilage degradation are closely related. Indeed, during cartilage degradation, there is a release in the synovial foot, in the joint cavity, of a lot of factors, agents capable to activate the innate immunity. You can find the DAMs. The DAMs include fibronectin fragments, hyaluron, type 2 collagen peptide, for example. The SAS, the senescence-related factors, include mainly GROW, TGF-beta, VEGF, but also cytokines like IL-6, IL-8, or metalloproteinases. You have also the crystals and mainly calcium-containing crystals. The complements, including the membrane attack complex, which can directly induce senescence and cell death, and also a lot of cytokines, mainly IL-1, TNF, IL-6, but also chemokines that may attract immune cells in the synovial membrane. These factors, when they are released, can bind to PRR receptors and activate cells present in the synovial membrane, mainly type A synovicites, macrophages, and T cells, which produce, in turn, MMP, ADAMS, pro-inflammatory factors that may degrade and accelerate the chondrolysis. Well, you have well understood that macrophages play a very key role in synovitis chronicity. And they are involved first in the synovial membrane, where they can crosstalk with chondrocytes and other cells in the synovial membrane. In the knee, they are also located in the fat pad, where they can communicate with adipocyte and induce inflammation of the fat pad, but also fibrosis. And they are also identified in the subchondral bone, where they can communicate it with cartilage, but also osteoblasts to control, induce some anomalies present in the subchondral bone, including the bone marrow lesion. What is very important, this is the shift between M1 and M2 macrophages. I remind you that macrophages may be M1 or M2 according their environment, according the status of the inflammation, and according the cytokines present around them. If you have an overproduction of TNF-alpha and IL-17, macrophage will shift to M1. M1, this is the macrophages involved in the cleaning up of, for example, debris, but also, for example, bacteria present in the joints. And when they are activated, this M1 macrophage produce a lot of pro-inflammatory cytokines. This is the type 1 cytokine set, and they maintain the chronicity of the synovitis. If they shifted in M2, based on the stimulation by IL-13 or IL-4, they become then what is so-called resolving macrophage, and they produce anti-inflammatory cytokines, and they are also involved in the healing of cartilage, for example. What is very important is that recently it was demonstrated that the ratio between M1 and M2 in synovial fluid of OA patient is increasing. What this means? This means that you have more M1, less M2. And what is very important is that this ratio is correlated with the Kerr-Green and Lorenz score, with the severity of OA observed at the X-ray. Well, it is clear that when and so long that macrophages receive cleaning up signals, they stay at the M1 inflammatory status and they overproduce pro-inflammatory cytokines, which induce MMP production by chondrocytes, and by this way induce the release in the joint cavity of a lot of DAMs. DAMs activate innate immunity, and mainly macrophages, neutrophils, and also natural killer cells, which can communicate it with adaptive cells, including T killer cells and T helper cells, which, according the severity and according the message that receive, produce either more anti-inflammatory, more pro-inflammatory cytokines, and by this way control the shift between M1 and M2. If you have a higher ratio of M2, you can expect that a healing phenotype of the cells and that the disease move to the resolving stage, and by this way the decrease of inflammation. And this is exactly for which in the future some company develop drugs that target M2 polarization to expecting to resolve inflammation. Well, now we will speak more about the infrapatellar fat pad inflammation that occur in the knee. I remind you that the fat pad is located just behind the patellar, and this is intracapsular but extrasynovial structure that play a role in the knee and protect the knee joint from mechanical damage. They stabilize, this structure stabilize the patella and serve as a cushion between the patellar tendon and the anterior tibial plateau. Unfortunately, in osteoarthritis, this fat pad undergoes structural changes, including an increase of the volume by accumulation of fat, an increase in inflammatory cells infiltration, an increase of vascularization and fibrosis, and of course, as a consequence, a decrease of the mechanical properties. Recently, the role played by the structure in OA physiopathology was well characterized. It was demonstrated that the severity of inflammation in the IFP was associated with the severity of pain in knee osteoarthritis. Increase of MRI signaling intensity is also associated with tibiofemoral structure anomalies. And finally, IFP MRI signal intensity is associated with the occurrence of knee replacement. What this means? This means that infrapatellar fat pad is also an important target when we want to treat osteoarthritis. Well, we will now move to the systemic low-grade inflammation, which is associated with osteoarthritis, and we can observe in osteoarthritis 3 important low-grade inflammation. This is the inflammaging, which is low-grade inflammation related to aging, the meta-inflammation associated with obesity, and finally, dysbiosis, which is a dysregulation of the gut microbiome. Recently, it was demonstrated that a subset of patients have an inflammatory signature, an inflammatory systemic inflammation, which is comparable to what is observed in rheumatoid arthritis. This author, Beijensens and collaborators, to demonstrate that, measure in the blood of OA patient a CRP, but also what is so-called the CRP-Hem, CRP metabolite, which is derived from MMP degradation of CRP locally in the joint. They have first observed that in OA patient, the level of CRP and CRP-Hem is increased, but for example, of course, to a lesser extent than what observed in early RA or moderate severe RA. But what was interesting is that they observed that half of the patient with knee osteoarthritis has level of CRP comparable to what is observed in rheumatoid arthritis patient. And they also observed that 1/3 of this patient had a very high level of CRP-Hem comparable to what is observed in RA patient. They have also observed that patients with moderate to very high CRP-Hem were 2.5 times more likely to develop OA in the knee with no OA at baseline. This means this CRP-Hem is an indicator of biomarkers of the occurrence of osteoarthritis. Well, it was also well demonstrated that no osteoarthritis is associated with the low-grade meta-inflammation. And this concept comes from a whole study published in 2008, in which the authors demonstrate the association between BMI and the risk of systematic osteoarthritis, not only for the knee, and you can observe here that the relative risk to develop knee osteoarthritis is more elevated in patients overweight or with obesity. But what was surprising is that these authors also demonstrated that the risk to develop a symptomatic osteoarthritis of the hand, which is not loading joint, is also increased. How can we explain that? And the explanation comes from the presence in the blood of adipocytes. And it was now well accepted that obese white adipose tissues secrete more pro-inflammatory cytokines, less anti-inflammatory cytokines, but also more adipokine than the lean white adipose tissues. And it was also demonstrated that the levels of, pro-inflammatory adipokines, including leptin, resistance, fatin, for example, increase with the BMI and the amount of fat tissue, whereas the level of anti-inflammatory adipokine decrease with the level of fat tissue and the BMI of the patients. Therefore, the link between osteoarthritis and fat tissue may be explained by the release of pro-inflammatory adipokine in the blood of the patient. Finally, I would like to highlight the role played by dysbiosis in this systemic inflammation. It is now well accepted that a lot of risk factors associated with osteoarthritis, including metabolic syndrome, trouble or disorders of the diet, aging, but also the overuse or the chronic consumption of drugs like NSAIDs, and of course obesity, may induce a dysbiosis, an alteration of the microbiota in OA patients. What is dysbiosis? This is an increase of pathobionts, this bacteria which have pro-inflammatory properties, and a decrease of the symbionts, which include bacteria that have anti-inflammatory activity. The second point is a decrease of the heterogeneity of bacterial species, and finally, an increase of gut permeability, allowing the passage in the blood of LPS, bacteria, or peptidoglycans, which can directly affect joint tissue and contribute to synovitis, pain, or cartilage degradation. Well, now I would like to try to represent this holistic view of osteoarthritis by this planetary representation in which the planet turns around two orbits. The first one, this is the biopsychosocial orbits, in which you have as a starting point the mechanical pain. This means that patients have fear to motion because they are, of course, they have pain when they move, leading to kinesiophobia, disability which is responsible for sedentarity, physical deconditioning, which lead to anxiety and depression, which create psychological deconditioning, which are all amplifier of the pain. This is the first orbit. Secondary, we now know that metabolic syndromes is risk factors for the occurrence, but also the progression of osteoarthritis, and participate to synovitis, which contribute to systemic inflammation, which is a physiopathological pathway of cardiovascular disease. And this could explain why the mortality linked to cardiovascular disease is increased in patients with, for example, knee osteoarthritis. What this means? This means that now when we treat osteoarthritis, we not only treat symptoms, pain, but we treat also a patient with comorbidities. And we have to treat comorbidities to well treat osteoarthritis. What are the most important take-home message from my talk is first that OA is associated to local and systemic inflammation, that local and systemic inflammation are associated to OA incidence and progression, and finally, that local and systemic inflammation are therapeutic target. And how can we treat inflammation in a way, locally by cold therapy, for example, and topical NSAIDs, orally with NSAIDs, but Professor Cooper will explain how use this NSAIDs, but also by CISADOA or food supplement like curcumin, for example, but also by intra-articular treatment, including corticosteroids and PRP. And what will be next? Next, this is the arrival of biotherapy with monoclonal neutralizing both IL-1 and TNF-alpha. Also biomaterials that release NSAIDs or corticosteroids, gene therapy targeting gene like IL-1 antagonist receptors, mesenchymal stem cells that may also release factors, anti-inflammatory factors, but also, of course, for example, controlled diets or treatments or comorbidities. Before concluding, I would like to remind you that the Osteoarthritis Day is next September 17, and not this date in your agenda. And it remains to thank you for your attention.